Our next speaker is Dr. Ed Keystone. Ed's professor of medicine at the University of Toronto and director of the Rebecca MacDonald Center for Arthritis and Autoimmune Diseases, Mount Sinai Hospital in Toronto. He received his medical degree at Toronto and his internship at Toronto General. He was a resident at University of Michigan and Sunnybrook Health Sciences Center of Toronto. He has a number of honors and recipient of the 2011 Congress Clinical Rheumatology Outstanding Speaker Award. That's got to be up there with one of the top honors, Ed. Canadian Human Proteome Project leader for rheumatology. He's founder of the Arthritis and Autoimmunity Research Center, and he's founder and chairman of the Canadian Rheumatology Research Consortium. And he's going to speak this morning on the therapeutic trends with biologics in RA.
Thanks very much. I just want to say it's great to be here. When I think about the weather in Toronto, it's great to be anywhere. However, having been here only for an hour or two, I'm not sure I can make that statement. I looked out the window and there was a lot of stuff out there. Now, I'm going to give such a dense and heavy lecture, you're going to have to take notes. So I gave you enough of a piece of paper as you've got in front of you to take notes, okay? I just saw the piece of paper. Don't worry, you can get it all on one. You might need 2 sheets, but I think you can get it on one. Okay, that was kind of interesting, the size of the paper, I must say. Okay, so what am I going to do? These are my disclosures. Everyone knows you have to do that, so here it is. Now you see it, now you don't. And what I'm going to do, I'm going to talk, my outline basically is to talk about what are the trends in terms of the use of biologics. Obviously, one of them is the switch from IV to SubQ, and the other is SubQ to IV. The other, for example, is the biologic monotherapy, dose reduction and withdrawal, and finally talk a little bit about biosimilars. And I'm going to talk about that because I'm personally involved in biosimilars, personally. So you'll see why in a minute. Okay. Emerging biologics. So here we're going to talk about the IV to SubQ, at least initially. You know one of them already, actually one's on the market. I say emerging because I'm a Canadian. Now, you've got, for example, SubQ Abatacept, and we might see it in the next millennium. So it'll be emerging for Canadians. Americans, I call you Americans, Americans will have it, but Canadians are still waiting for it. Okay, so we're talking about SubQ Abatacept, and here you know this is the ACQUIRE trial. So it's a large trial, 700 and something patients, IV Abatacept versus SubQ Abatacept. The SubQ is weekly in the dose of 125 milligrams per week. And then the question is, are they really the same? And so they did the study, obviously, head-to-head comparison. And the data is right here. And that's all you need. You see one slide, that's all you need to see. Interesting that the ACR20, I never know which way to go here, but it does peak around 3 months appropriately. The ACR50, as Abatacept IV in the past, took a little bit longer, so it didn't peak at 24 weeks. It was about 36 weeks. You can see it's still climbing at 24 weeks. And then you have the ACR70, which normally keeps going up with most of the trials. So it was very consistent. And then you look at the ACR20, 50, 70, and you say, excuse me, this isn't 60-40-20. You know, that was called the Keystone rule, 60-40-20. You know, 60% ACR20, 40% ACR50, and 20% ACR70. It is 75-50-25. Wow, how did they do that? And the answer is easy. No placebo. You're doing a head-to-head, you tell the patient you're going to get something, everybody gets better. So the 75-50-25 really reflects a head-to-head trial with no placebo. Now, after they did that, they said, okay, SubQ looks like it works. Now we have to really go head-to-head mono a mono against, one of the TNF inhibitors. So they choose adalimumab to go head-to-head, and again, a non-inferiority type study. And they really asked the question, do we look like, clinically, do we look like radiographically like adalimumab? And you know that Abatacept was tarred with the brush of They don't have as much radiographic inhibition because, in fact, they used the Genin score instead of the Van der Heide score, and they said because of that, there was only a 50% inhibition in radiographs rather than 85%. So they said, well,